we stay like that, it's not that a big issue. So I was there stating that you have to know the sampling airflow to calculate the output, the NO output, because it's just multiplying the results you'll obtain from your machine in ppb, the concentration, and you multiply it by the airflow to obtain the output. And so the thresholds are generally done in output, but the concentration will depend on the airflow of the machine, and there is no linear relationship. So if you're using a machine that has a very different sampling airflow from the cutoff you wish to use, it's wrong. It's not good. You will have wrong interpretation. So that's the first issue I wanted to point out. Second, and I think Jane has nicely explained all this, but I want just to share a few results with a survey that you might have taken part in on the natural nitric oxide measurement in children. And you can say that most of the people, 70% of the people answering the survey would postpone the measurement in case of a recent respiratory tract infection, which is good. The duration of the delay is not set yet, but you see it's few weeks. And then, of course, if the child has total nasal obstruction, you won't be able to sample the air from the nostril. But the trouble is when there is a partial nasal obstruction, and it's quite difficult to diagnose this because you would have to see the middle meatus, which is not permeable, and you can't see that. So that's why you have to postpone when there's been a recent respiratory tract infection, because you suppose that even though the child might be able to breathe through his nose now, the middle meatus might be still edemated, and so the nitric oxide won't be able to communicate to be sampled from in the nose. A third thing from the environment is the ambient NO. I won't talk much about it, but as you can see, many centers who answered the survey thought it was an important issue, and they measured the ambient NO to know whether their result could have been false by this. And then of course, you always have to measure the nasal nitric oxide before the child perform forced expiratory maneuvers, or when he or she blows her nose, you have to wait a few minutes for the nitric oxide to reappear in the sinus and the node. In preschool children, there is mainly 3 respiratory maneuvers that are used: the expression against resistance from total lung capacity and until a plateau of NO is reached, the breath hold, while the child is supposed to close his glottis to close the velum, which is not easy, until a plateau is reached, or the tidal breathing method, where the child is supposed to breathe regularly through mouth or nose, it depends. But you have to check for the regularity of the measurement, and you take the reproducible 5 peaks, the mean of the reproducible 5 peaks at the measure. And as the velum is not closed, it's open, you have dilution of NO of nasal NO from lower airway air, and so the result, as explained Jane before, is lower than that obtained with measurement performed with the velum closed, which is the expression against resistance or breath hold. And how many nostrils do you have to sample? Well, again, in our survey, nearly 2/3 of the centers sampled both nostrils, and we will see in the slide after this why. And again, how would you say a result is reproducible if you sample the other nostril? And most of the centers use a 10% reproducibility cutoff. So measurement in preschool, you have to, of course, explain the device and what is going to happen to the child. I insist on the child being facing the screen, because if there's a screen, I mean, and because you have to put a hand at the back of the head of the child, and while putting the olive in the nostril, because if you don't do that, the child will move backward, and then you have leaks around the olive. If the child is sitting in his or her parent's lap, then the parents has to face the screen, so the back of the child is against the torso of the parents, and again the child cannot move backward. Then you have to buy a party blower if you want, because it's much fun for the children. And then of course you have to have time to deal with young children. And now we'll see about the traces. So that's where it's less funny. So please follow what I say. Now we're looking left first, because it was not, you were not supposed to see the right part. So just look at the left part of the slide. And so you see that it's a nearly 5-year-old boy. This is expression against resistance in the right nostril. And there's many attempts, but no one is good, because the duration of the plateau is not 3 seconds. So it's not a plateau, but it's quite high, between 700 and 800 ppb. And the other information you can have from this trace is that the ambient NO is very low, because it's 0. Okay. So you don't have a result, you just have an information. But then the child succeeded, and now he has an at least 3-second plateau, and it's written here, the plateau. And then it's a plateau because the difference between the minimum and maximum is no more than 10%, and the result is very high, so it's normal. Okay. And now we turn to a younger girl who is not able to perform expiratory maneuver, expiratory against a resistance maneuver or breath hold. She's just tidal breathing, and we can have quite regular peaks of tidal breathing here in the left nostril, tidal breathing. And again, when we checked for this, it was again quite regular values of NO. Around 500 ppb, so it's normal. And again, the ambient NO, we can see it here, is low. So this is perfect traces. And why I show you this is just because to show you now not perfect traces, because life is not perfect. So we will now look at this part of the screen. So this is a 4-year-old boy who is coming for the first time in our laboratory, and the first tidal breathing in the right nostril, you see, is very irregular. It's slow and irregular. So we said, okay, we try the left nostril, and it's the breathing pattern is regular, because this is not the flow, this is NO. So it means that the child regularly breathes, but the NO result is not regular. It's high here, then it decreases, then it decreases, and I put here the threshold, so it's higher, lower, and just at the cutoff. So what do you do in this case? You perform a second measurement in each nostril. So the second measurement in the right nostril, you see, is low, but more regular than this one. And in the left nostril, it's now very low. So you got discordant, irregular result traces. You don't know what is the real results. You don't know whether it's over or under the cutoff. So in that case, you just have to see the boy a second time after oral antibiotics. And then you see this is the same child. It's not the tidal breathing now in the right nostril is regular, and in the left nostril it's regular, and it's reproducible. It's exactly the same number, so you're very happy. And so you see the result is that it's 500 ppb, so it's higher than the threshold. And the information you don't have from this trace is ambient NO. So you learn French now, and it's very close to English. So you see that the ambient NO is low, so it's good. And then also you speak French now, and you see that the child succeeded blowing against a resistance. And so indeed, this child, the second time, succeeded in reproducible correct plateau. So it's okay. So really and the result was normal. So it would have been a pity to give a result the first time the boy came, and probably a low result, which was wrong. It was a really high result and not in favor of PCD unless he has specific mutation. So now look at the left part of the slide, please. And you got here a girl who has irregular peaks of NO while breathing regularly. But then it's the peaks are very high, okay, on the right nostril, and on the left nostril it's much more regular. You get regular peaks, and the result is also high. Okay, so you got result which is normal. However, I would not be able to know which result to give, probably the left nostril. But suppose you're in a setting, or you're a person who cannot perform tidal breathing because you don't know how to perform it, you've not learned. And so you would try in that 5-year-old, because the American recommendation says that after 5 years of age you can perform expiratory against resistance. So you will try, but the girl failed. So you could try to do breath holding, and the girl, well, was able to perform some measurement with breath hold with a plateau more than 3 seconds, and the value, the results were quite just at the limit of the threshold, you know, just under or over the threshold. So you don't really know. So if you don't perform the tidal breathing in this child and you just perform the breath hold, you don't know exactly if the result is higher than the threshold or not. But if you know how to handle tidal breathing method, you can compare the results of the tidal breathing method, for example, the left nostril, and see that it's higher than with the breath hold maneuver, which is not possible because, as Jane explained to you, during tidal breathing, we have a much lower value of NO than during breath holding or expiratory against resistance. So it's very helpful to perform tidal breathing in young children, even if they are able to perform a correct plateau of NO, because they might have a wrong technique and don't close the volume satisfactorily during, especially during breath hold, more than during expiration against resistance. So again, now you could say, well, I got an electrochemical device, so I don't see the traces. So imagine you don't see the traces. Look at the left, at this trace. You don't have it. It's not a preschool. It's a teenager. She's breath holding and wrongly breath holding, but you don't see it. So you just have the results from the machine, which say that it's a low results. Okay, so now you say I got a low results with one technique. I will try another nostril and another technique. So you try the expiration against resistance, and you can see that the result is normal. It's high because she was wrong doing the breath hold. But now suppose she was not able, because instead of being a teenager, she was a preschool child, and she was not able to perform expiration against resistance. You could perform tidal breathing in this child and see that the result of the tidal breathing, and as you have an electrochemical, you don't have the mean of the peaks, the 5 peaks, which is a 431 ppb result, but you have the line under, you have a mean of a period, either 10 seconds or 30 seconds, depending on your machine, but it's quite close. It's around 300 ppb. So you see that the result is high, and it's higher than the threshold, even the threshold with expiration against resistance, but it's higher than the first measurement. You couldn't see that, but it was wrong in terms of technique. So this is not possible. So performing tidal breathing again can confirm or not whether a low measurement is true. So I think if you got, I don't know if I have time because of the timing, and we were late. Can I continue?
5 minutes.
Oh, sorry?
Yes, there are 5 minutes, and after that we will take the questions.
Okay, so if you have the Niox Vero, I think you have access to this, because I had, and you can change the way you want to select the curve. But as you see in tidal breathing, you don't really have peaks. So I think the tidal breathing of the Nux Vero is also a mean of a few seconds that you can select. And then the only thing I wanted to point out here is that this kind of peak, which make you suspect during breath hold or expression against resistance that the child has a busy nose and the measurement is unreliable, you cannot pick this with the Nux Vero machine. So it's only in chemiluminescence, and it's very important. So again, when the result is low in a preschool, perform the tidal breathing method, and then you will discuss the results. And so last to finish is the ambient NO. You see, for example, this child has quite regular NO peaks, but if you see the ambient NO, which is high, and you subtract it from the peaks, you get quite a low level of NO. So you don't really know which measure the NO is for this child. So it's better to schedule a second measurement and hope for a low level of NO on that day. Or at least you have to measure it, because you have to be aware that some of the ppb included in the peaks can come from the ambient NO. So in conclusion, I would say that the measurement of a nasal nitric oxide is really doable from the child side, but you have to be critical from the technique. And when you have a method with the volume closed, it's quite useful in this age group to confirm it with a tidal breathing method if you don't have a PET CO2, but I suppose most of you don't have this technique available. And low or borderline results must be confirmed in the contralateral nostril or on another day or with another technique, etc. And then the ambient NO will, of course, more impact tidal breathing results than results obtained with the volume closed, because the value of NO is lower. So it's a question of proportion. So it's okay. I thank you. I don't know whether I have my small quiz, which is just 4 questions for you to answer, or if you want to go back to Jane's. I don't know.
You carry on.
Okay, so this is just a quiz. So you just have, I just have 4 questions. First is ambient NO high? Second is breathing pattern regular? Third is, are the NO peaks regular? And then finally, which result would you give to the person who referred to you, the child? And so I don't know how we deal with that. Just take a thought, and we'll discuss this after. I don't know. I can stop the sharing now and let Jane with her quiz. Or
Okay.
Or do you want to give us the answer to that?
Okay, so the ambient NO is low. As you can see, it's very low. The breathing pattern is regular. You need a child in terms of rhythm. It's regular. This is not airflow, so this is NO. So it will just give you the timing of the breath. So it's quite regular, but the peaks are not regular at all. And I don't know what is the result of the natural nitric oxide of this child, but I know I have to do it again another day, probably. Okay, so thank you. We stop this.
I would like to thank Jane and Nicole for these inspiring and excellent talks. Jane?
Okay, so I have some quick questions just to see if people feel they've understood. If you'd like me to go through them, if we have time.
Yes, we have 9 minutes later.
Okay, so so these are just some questions to make you think. Usually we'd have this as an interactive session and we'd have hands-on if we could all meet each other. So Nicole and I just thought that having some questions would make it slightly more interactive, although you can't tell us the answers. So thinking through these, in patients, are these right or wrong? Patients with normal cardiac situs should not usually be referred for PCD diagnostic testing, as the likelihood of a positive test result is low. So the answer to that is patients who've got the right symptoms, even if their cardiac situs is normal, they need referral, because over 50% of patients with PCD have normal cardiac situs. So the next question, nasal nitric oxide is a useful screening test in a primary care setting because it has a high predictive value. A minute to think of that. So, and the answer to that is wrong. So it's false, because as I told you, if you do any test in a population where most people don't have the condition, it's going to be mostly false positives you get, and your diagnostic services will be overwhelmed. So however good the sensitivity and specificity are, you need to have a good pre-test reason for doing it. So you need to have a good history taken first. Use of symptom compensations and predictive tools such as PCD might improve selection for patients for diagnostic testing. And I think we've mentioned it several times that yes, they do help. So that's a good screening tool. And all patients with a history of neonatal symptoms should be screened for PCD. And I think we've all come to the conclusion from the discussions during our talks that that's not the case. We only want to see patients whose history fits PCD with more than neonatal respiratory symptoms. We don't want to see every preterm infant. And cutoff values for tidal breathing, nasal nitric oxide to help predict PCD in young infants. If you think back to my talk, we decided that wasn't the case. You're actually going to need to use algorithms because different ages of infants are going to have different cutoffs. So you're going to have to have normal curves rather than a standard cutoff as we use for older children and adults. So that's Nicole and my questions and talks finished. So I think we're happy to take questions.
Thank you for these nice talks. And there are a few questions in the chat. First question is from Anna. Also, there is already a reply for this question. In Shield, we don't have chemiluminescence equipment, only NeoxVero for nasal nitric oxide. What are the cutoff values in ppb? And Claire has referenced, do you have any recommendations for this NeoxVero equipment for the cutoff values?
Not really, but first she has to know the sampling flow, whether it's 0.3 liters per minute or not, because well, it's part of the answer. But I think the threshold might be a little bit higher with electrochemical device compared to chemiluminescence. So we need to have more studies, including more patients, to really have a reliable threshold using the electrochemical device.
Okay, thank you. Another question is from Zeynep Rehan. Thank you for a great training school. What is the role of exhaled nitric oxide measurement in the diagnosis of PCD instead of nasal nitric oxides? And she thanks to you. Exhaled nitric oxide. Do you recommend exhaled nitric oxide for PCD screening?
Shall I answer this? And the answer is no. So it will be low in patients with PCD, but to get the discriminatory values, you really need to be using nasal nitric oxide levels. So no, unfortunately, no is the answer. You need to have the kit to measure nasal nitric oxide levels.
Okay. Another question is from Line. Is it known how long nasal nitric oxide takes to normalize a post-infection period? Is there any time?
No, I'm not aware of any good evidence for that. In our centre, we wait for 4 to 6 weeks because in our experience, we do nasal nitric oxide and then we take nasal brushing after it on the same day. So we avoid seeing people when they're unwell, because not only is the nasal nitric oxide level low, but the brushing's obviously often compromised as well. So we tend to wait 4 to 6 weeks. As Nicole presented in the survey, some centres are using 2 weeks. I don't think there's good evidence as to what that time frame should be. Are you Nicole? Do you know?
No, I just mentioned that in our survey, it was between 2 and 4 weeks in general, based on, well, no evidence. But I suppose that, well, for us, it's 3 to 4 weeks again. But I suppose that if people have seen children 1 week after the first measurement and so that the level was low and the nose was still busy, so it's from experience that people made the child comes 4 weeks after, I don't know roughly. But in Martin's paper, you can see a child, the result from one child, and you can see that the increasing of the NO was quite slow after the respiratory infection. So.
Okay, thank you. Another question is from Lei. What is the conversion factor from ppb to nanoliter per minute?
Yeah, I'm sorry, it was my first slide, who was very difficult to see. You just have to, sorry for this. You just have to multiply the ppb, the concentration, by the sampling airflow of the machine in liters per minute.
Okay.
And then you obtain the nanoliters per minute.
Another question from Kathy. Are you aware of studies currently happening at the moment to create normal values for infants?
Not aware of, Jane?
No, I'm not aware of. And I think it would be a really nice study to do. I think we're going to need such large numbers that it's going to be a multi-center study, probably, particularly if we're going to need to also then get the data about infants with PCD to map onto that.
I think that would be the point. It's not only to measure healthy. I think we would need to have healthy, non-healthy, non-PCD, and PCD, which is a great job.
Yes, I agree with you also. Another question is, are there any new ideas for why nasal nitric oxide is low in PCD?
Sorry?
Are there any new ideas why nasal nitric oxide is low in PCD?
Not from my side.
So one of my colleagues, Wolf Walker, wrote a very nice review article in the European Respiratory Journal, I think in 2014, on this, and didn't really come to any definite conclusions. The sinuses are certainly opaque when we look at them in patients with PCD, so, and hyperplastic, so it might have something to do with that. But really, we don't know is the answer. But look at Wolf Walker's paper about why nasal nitric oxide levels are low. But the short answer is we don't know.
Okay, this is the last question. Would it be recommendable to determine nasal nitric oxide in a patient with situs inversus without any other symptoms? The question is about if the patient with situs inversus without any other symptoms, do you recommend to measure nasal nitric oxide?
So I think it would be a very reasonable thing to do. It's 20 to 25% of patients with situs inversus probably have PCD, so it's actually quite a reasonable chance just on the basis of situs inversus that they have the condition. I wouldn't be doing it in infants at the moment for the reasons that we've said. We haven't got enough normative data. But actually, even if the patient's got isolated situs inversus and no other symptoms, they're probably going to be in the 80% of patients that with situs inversus that don't have PCD as their symptoms. But yeah, I'd measure nasal nitric oxide level in someone with situs inversus when they're a bit older.
Okay, I think it's It has finished in the chat. My last question is about in the diagnostic pathway, we need just one times nasal nitric oxide measurement, I understand. For high-speed video microscopy, we usually recommend 3 times, or we usually recommend cell culture. For nasal nitric oxide measurement, we just recommend 1 times, I understand. It has good technical aspects. We usually use 1 times. Is it true?
Well, from our side, we always, as I stated, we always check on a second occasion any low nasal nitric oxide level.
Okay.
So it might be one result, but it might be the result of 2 occasions. I mean, I think it's, well, we don't have yet guidelines, but it's coming. But in the American guidelines, at least, it's the same. It states that you have to check on another occasion for any low level of nasal nitric oxide, especially in the preschoolers who have frequent rhinitis. And well, BCD have rhinitis, but acute rhinitis. So you never know whether you are far enough from an acute episode, and well, it's relevant to control it at least once. So I think it would be twice, but it might not be written like this. I understand.
So just from a practical point of view, though, I agree with Nicole, but from a practical point of view, patients often come to a PCD centre from a very long way away, often long distances. So we wouldn't require at our centre two low levels before going ahead to do electron microscopy or high-speed video or genetics testing. If we had a good history and low nasal nitric oxide level on one occasion, we'd still take the brushing that day, but I agree that you'd still want confirmation of the low nasal nitric oxide on another occasion.
Yeah. Scheduling a second venue doesn't mean stopping the other tests.
Yeah, exactly.
It's just...
Okay. I think the questions has finished. I would like to thank all speakers and participants, and I would like to thank my co-chair Suzanne for this session. I think we will close this session.